Substance P, pain, and neuroinflammation in glaucoma. Glaucoma is a chronic eye disease that damages the optic nerve and can lead to vision loss. Many people with glaucoma also suffer from ocular surface discomfort, redness, burning, or dryness of the eye, especially if they use eye drops or have surgery. These symptoms are not only uncomfortable, but they can make it harder to stick to glaucoma treatment. Researchers have discovered that substance P, a small protein, neuropeptide, released by nerve endings, plays a key role in eye pain and inflammation. Understanding how substance P works may help us treat these symptoms. This article explains substance P's role in eye inflammation and pain, why that matters for glaucoma patients, and what studies tell us about drugs that block this pathway. Importantly, we distinguish easing symptoms like dryness or pain relief from protecting vision, slowing the nerve damage in glaucoma. Substance P and neuroinflammation. Substance P, SP, is a signaling molecule made by nerve cells. When nerves are irritated or injured, they release substance P into the surrounding tissue. Substance P then binds to its receptor, called the neurokinin 1 receptor, or NK1R, on nearby cells. This triggers several effects. Blood vessels in the tissue expand and become leaky, immune cells, like white blood cells, are recruited, and inflammatory chemicals, cytokines, are released. In simple terms, substance P tells the body, something's wrong here, send help. This process is called neurogenic inflammation. It helps fight infection or heal damage, but it also causes redness, swelling, and pain. For example, in the cornea, the clear front of the eye, substance P causes blood vessels to dilate and immune cells to come in. It also directly amplifies pain signals by acting on nerve fibers, A lead and C fibers that carry pain to the brain. Because the cornea is one of the most heavily innervated tissues in the body, it can produce and respond to a lot of substance P. Normally, a small amount of SP helps regulate tear production and blink reflexes. But after injury or chronic irritation, such as allergic or dry eye, SP levels can surge. High SP can make the cornea and conjunctiva, the white part of the eye, much more sensitive and inflamed. In experiments, blocking SP's action strongly reduces inflammation. Nerves that lack the SP receptor show fewer immune cells arrive, and mice missing SP themselves have less swelling. In other words, substance P turns up the inflammation and pain in the eye. Why substance P matters for glaucoma and ocular discomfort. Glaucoma itself is characterized by loss of retinal ganglion cells, RGCs, in the back of the eye, the retina. However, many people with glaucoma experience ocular surface symptoms unrelated to vision, dryness, burning, soreness, or red eyes. These often come from eye drop preservatives or inflammation from surgeries, and they can involve substance P. For example, irritating drops or foreign substances on the eye surface make corneal nerves release more SP, which then increases inflammation and pain. Studies show that when the ocular surface is inflamed, trigeminal nerves, the ones sensing the eye, begin to express much more substance P. This creates a vicious cycle. Dry or injured eyes produce SP. SP causes more inflammation and nerve sensitization, which then increases discomfort and tear instability. For glaucoma patients, increased ocular discomfort can reduce quality of life and treatment compliance. While wearing contact lenses or undergoing surgery even temporarily raises eye SP levels, glaucoma medication, especially those containing benzalkonium chloride, also irritates the ocular surface. By fueling eye pain and redness, SP can make glaucoma treatment more burdensome. Addressing this neuroinflammation could therefore ease symptoms, improving comfort. On the other hand, glaucoma is fundamentally about protecting the optic nerve and vision. Emerging research suggests that substance P has roles in the retina too, where it may actually help keep neurons and blood vessels healthy. For instance, a mouse retina study found that adding substance P protected retinal ganglion cells from experimental injury, excitotoxic damage, and helped seal the blood-retina barrier. In that setting, SP reduced cell death and prevented leakiness of retinal vessels. These findings hint that SP's actions can be context-dependent. In the front of the eye, SP tends to drive inflammation and pain. In the back of the eye, SP might support cell survival. This difference highlights an important point. Treating eye pain, symptoms, is not the same as treating the disease, glaucoma. Many treatments like anti-inflammatory eye drops or NK1 receptor blockers can relieve pain and redness, but they do not directly lower eye pressure or stop optic nerve damage. Conversely, lowering eye pressure with glaucoma surgery or medications preserves vision but might not relieve surface discomfort. Future therapies will need to address both aspects, calm down harmful inflammation to ease symptoms while also protecting retinal cells to preserve vision. Modulating substance P research in eye disease. Researchers have tested various ways to block substance P signaling in eye disease, mainly by using NK1R antagonists. Most work is still experimental, animal studies and early human cases, but results are encouraging for symptom relief. Preclinical studies, animal models. Dry eye and corneal pain. A recent mouse study induced dry eye by drying out the eyes and then tested an NK1R blocker, L73360, a research drug, as eye drops. Mice that got L73360 had much less pain, measured by wiping a hypertonic solution and more normal eyelid opening. Their corneas had lower substance P levels and healthier nerves. In fact, the treated group had preserved corneal nerve fibers, whereas untreated mice lost nerves from inflammation. This shows that blocking SP in dry eye can relieve pain and protect nerve anatomy. Key endpoints were pain behavior, SP amount, and nerve density. Neurokinin 1 antagonists, animal trials. Investigators have studied FDA-approved NK1 blockers used for nausea and chemotherapy as potential eye drops. For example, nasally blocking NK1R, topical fosaprepitant drops in a mouse model of acute corneal pain greatly reduced pain behaviors. In one experiment, a single drop of fosaprepitant at 1 to 5% concentration virtually stopped salt-induced eye pain in mice. Even at lower doses, 0.2%, repeated use over days relieved pain. Fosaprepitant also lowered substance P levels in the tear fluid and inflamed corneas, and it reduced immune cell infiltration. Another study used aprepitant formulations, 2 gel versions, in a mouse model of toxic dry eye. Topical aprepitant reduced corneal staining, less epithelial damage, and wiping pain compared to artificial tears or even steroid drops. It improved corneal sensitivity and nerve density, and decreased white blood cells on the surface. In short, in animal eyes blocking the SP receptor, NK1R, with drugs like L73360, fosaprepitant, or aprepitant, consistently reduced symptoms of ocular pain, inflammation, and nerve damage. Retinal effects of substance P. As noted, some lab studies delivered substance P into the vitreous cavity to test retinal cell survival. In those cases, SP acted protectively, reducing death of retinal ganglion cells under stress. This suggests that in the retina, SP may have beneficial neuroprotective signaling. However, no studies have yet tested NK1 blockers for glaucoma itself. All current glaucoma treatments focus on pressure lowering. SP modulation research is so far on surface pain or retina models. Clinical experience, humans. Human experience with SP blockers for eye disease is very limited. A few case reports and small trials give early signals. Case series of fosaprepitant, 3 patients. Italian eye researchers reported treating 3 patients who had chronic, severe ocular pain despite usual treatments. These patients had inflammatory surface diseases, not glaucoma itself, and were given fosaprepitant eye drops for several weeks. 1 patient got a low-dose drop, 0.01%, and 2 got higher dose, 1% drops, twice daily for 3 to 4 weeks. Pain was measured on a visual analog scale, VAS, and with a dry eye questionnaire, OSDI. All 3 patients reported large pain reductions after just 1 week of treatment. Doctors also noted healing of corneal surface damage and less redness. Importantly, none had any adverse effects or changes in eye pressure. When treatment was stopped, pain gradually returned and improved again on retreatment. This small report suggests that topical fosaprepitant can strongly ease eye pain and inflammation in people. Translational vision science study, preclinical. In a preclinical dry eye model using benzalkonium chloride, researchers tested 2 experimental aprepitant gel formulas. One formulation, X1, significantly outperformed vehicle and even a steroid eye drop. It reduced corneal staining and pain, and improved nerve sensitivity and density in treated mice. This study has no human data yet, but it shows how an SP blocker might work in a more realistic dry eye setting. Ocular surface pain summary. A review by Lasagne Vitar et al. Summarized that inhibiting SP strongly inhibits corneal pain, inflammation, and neovascularization in multiple lab models. Levels of SP are known to be elevated in tiers of patients with severe ocular inflammation. These authors point out that fosaprepitant, brand Emend, an approved anti-nausea drug, can be easily formulated as eye drops and may become a novel ocular pain therapy. Overall, the key endpoints in these studies include pain measures, behavioral tests in animals, e.g. eye wiping after irritation, and patient pain scales, VAS or questionnaires, to quantify relief. Ocular surface signs, corneal fluorescein staining to see damage, redness, and biopsies for immune cells. Corneal sensitivity and nerves, Cochet-Bonnet aesthesiometry in patients, and nerve density by confocal microscopy in animals. Tier SP levels, substance P concentration in tears or trigeminal ganglia as a measure of neurogenic activity. Visual outcomes. In glaucoma context, any visual field or retinal nerve fiber layer changes would be the ultimate endpoint, but such data do not exist yet for SP therapies. A common dosing route in all these eye-focused studies is topical eye drops. For example, mice received small drops of NK1 antagonists directly on the cornea. In humans, the reported case series used eye drop bottles. The concentrations tested vary widely, from 0.1 mg/ml up to 50 mg/ml in animal models. For reference, 10 mg/ml is 1% and 0.1 mg is 0.01%. Formulation details are still experimental. One study used a gel, a prepitant, in hyaluronic acid, and others used solutions. The drops were typically given 1 to several times daily for days or weeks, depending on the model and severity. Easing symptoms versus protecting vision. It is crucial to understand the difference between symptomatic relief and neuroprotection. Substances that ease symptoms, like an SP blocker, reducing eye pain and redness, can greatly improve comfort and quality of life. That kind of therapy often works quickly because it directly interrupts pain signaling or inflammation. Indeed, all the studies above show fast improvements in pain scores and surface healing. For patients, this means they might feel more comfortable, use their drops better, and have fewer side effects from persistent irritation. However, symptom relief does not automatically protect the optic nerve or slow glaucoma. Glaucoma is driven by high eye pressure and other neurodegenerative processes. The standard approach remains lowering pressure with drops, lasers, or surgery, which is proven to save vision. A medication that only blocks substance P would not change intraocular pressure or ganglion cell metabolism. Likewise, an NK1R antagonist might reduce inflammation in the back of the eye, theoretically, but no human trials have shown it can preserve visual field. In summary, current SP-targeting treatments should be viewed as comfort therapies, like lubricating drops or light steroids, not as cures for glaucoma. Of course, research on glaucoma neuroprotection is active, e.g. NMDA blockers, calcium channel blockers, antioxidants. But nothing is yet proven in clinics besides pressure control. Any future SP-based treatment for glaucoma would need rigorous trials showing it not only relieves symptoms but also slows nerve loss. For now, we must manage expectations. Blocking substance P can make the eye feel better and reduce ocular surface inflammation. But it is not a replacement for glaucoma therapy that protects vision. Safety and regulatory status. Fosaprepitant IV and aprepitant oral are already FDA-approved drugs for preventing nausea in chemotherapy patients. Their known systemic side effects are mild, e.g. fatigue, constipation, since they largely affect the brain's vomiting center. Importantly, they have not been approved for eye conditions. Any current use on the eye is experimental or off-label. Fortunately, the few studies on ocular use report good safety so far. In the human case series, patients used fosaprepitant drops daily for weeks with no side effects. Their eye pressure stayed normal, and there were no signs of toxicity. Animal studies likewise did not note adverse effects at the tested doses. Since SP blockers work on nerves and immunity, theoretical concerns could include affecting tear production or corneal healing, but these have not emerged in the limited data. Topical formulations would need to be pH-balanced and preservative-free for long-term use. Currently, only small compound research formulations exist for eye drops. No pharmaceutical company has yet launched an SP blocker eye drop product. However, patents have been filed and research is growing. Given that fotepitant and aprepitant are already approved drugs, repurposing them as eye drops could be faster than entirely new drugs. Any future eye drop would still require clinical trials for safety and efficacy. Until then, these treatments remain investigational. Besides NK1 antagonists, other ways to modulate substance P include using enzymes that break it down, neutral endopeptidase, or designing antibodies against it, but such approaches have not reached eye research yet. For now, neurokinin 1 receptor blockers, like aprepitant, fosaprepitant, are the main strategy under investigation. Conclusion: substance P is a natural pain and inflammation signaling molecule in the eye. When overproduced, it contributes to ocular discomfort by causing nerve hypersensitivity and swelling. In glaucoma patients, where ocular surface disease is common, blocking substance P can therefore help ease symptoms like pain, burning, and redness. Preclinical studies in dry eye models and small human reports suggest that topical NK1 receptor antagonists, drugs that block substance P, can significantly reduce ocular pain and inflammation without obvious side effects. However, there is a crucial distinction. Relieving pain or inflammation does not equal treating glaucoma. Saving vision in glaucoma means preserving retinal ganglion cells and controlling eye pressure. Substance P blockers have not been shown to affect these long-term outcomes. They are best viewed as a supportive therapy to improve comfort and ocular surface health. In the future, we hope for treatments that both protect vision and make eyes feel better. For now, eye care providers should continue primary glaucoma therapy to protect vision and consider emerging SP-related therapies as a way to improve patient comfort and quality of life. Patients should always discuss any new treatment with their doctor. Currently, SP blockers for the eye are still experimental. Sources, research studies, and reviews of substance P in eye disease and pain support these points. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.